At this ASH meeting, we are participating in a pooled analysis of the wKRd-D regimen with datasets from other institutions, and we show that wKRd-D is very safe and highly efficacious. We have built on that, and we have designed a phase 2 study that's conducted at our institution only. And we also modulate a little bit the doses of carfilzomib as part of this new study. So we gave carfilzomib only once a week at a slightly higher dose, 56 milligrams per meter square, instead of the 36 milligrams per meter square, which was the dosing we had in the previous twice a week dosing. And then we added also the monoclonal antibody daratumumab. What we show in this phase 2 study is if you treat 8 cycles of daratumumab wKRd with the dosing schedule I mentioned, we achieved around 80% MRD negativity. And this is in the absence of a bone marrow transplantation. This is a very high rate. Just a few years ago there were 10 or 15% MRD rates. And you can see with the RVD or VOD regimen that the MRD rates probably in the range of about 25%. So the 80% MRD rate is quite something. Because of the striking results of close to 80% MRD negativity, this has already triggered us to develop the next step. And we have already developed a large randomized multi-center study that will use the weekly daratumumab wKRd-D regimen as the experimental arm, and then there will be 2 control arms. One will be the RVD regimen, and the other one will be a weekly wKRd-D regimen. And the primary endpoint in this study is MRD negativity. This study is anticipated to open before the end of 2019. So if this study pans out the way we project, I think its design is quite bold. Using MRD as a primary endpoint is something that has not really been done in any of the finalized studies at this time in multiple myeloma. Also because patients can be treated on this study independent of transplant status with MRD as the primary endpoint. It would also be a study that would kind of erase the old terminology of transplant eligible, transplant ineligible. Patients could go on the study either way. And looking at the phase 2 study, I was just talking about that I am presenting here at the meeting. When we look at patients who are diagnosed above the age of 65, they do equally well. So I think this new study will have MRD as a primary endpoint, which is new, and also it will give access to the most effective therapies to patients that are above age 65. There is no discrimination by age. So I think that's a huge step forward for the field. When we reviewed all the toxicities and compared that to our institution's own database, when we compared it to what we see with the standard of care wKRd regimen that is in the NCCN guideline, as I mentioned before, we see very similar toxicity profile. There is no new added toxicity. I should caution and say that a phase 2 study is a single arm design. It has a relatively small number of patients. The total number of patients on this study is 41. And the current follow-up, the median follow-up is less than a year. But so far it looks both very safe and highly efficacious. We are very excited about this.